She brought a list, not a short one. She had written it out by hand, in the careful cursive of someone who had been thorough her entire life. 7 medications, each one with the prescribing doctor's name next to it, each one with the condition it was prescribed for, each one with the dosage and the time of day she took it. She was 71 years old. She laid the list on my desk and said, "I take everything they tell me to take. I never miss a dose. I do everything right." And then she said the thing I have heard more times than I can count in 30 years of geriatric medicine. So why do I feel so terrible? I looked at her list. 7 medications, 4 different prescribing physicians. Not one of them had ever seen all 7 together in the same room. The cardiologist who prescribed her blood pressure medication had never seen the sleep aid her internist had added 6 months later. The internist who added the sleep aid had never seen the muscle relaxant her orthopedist had prescribed after a knee procedure. The orthopedist had never seen the acid reflux medication she had been taking for 4 years, prescribed by a gastroenterologist she no longer saw regularly. Each physician had done their job. Each prescription was medically appropriate for the condition it was addressing. Each drug had been tested for safety. None of them had been tested together, in her body, at her age, at the doses she was taking them. That is not a gap in one physician's care. That is a gap in how medicine is practiced everywhere, for almost every older adult in this country, and it may be the single most common cause of unexplained suffering in adults over 60. I am Dr. William Harris. I am a geriatric specialist, and what I am about to tell you today is something that the majority of adults over 60 who take 5 or more medications have never once been told by any of the physicians who prescribe them. The problem is not your medications. The problem is that nobody has ever looked at all of them at the same time. Today I am walking you through exactly what happens inside the body when multiple medications interact, why the risk is not additive but exponential, the 5 most dangerous combinations that standard prescribing almost never catches, and the exact conversation you need to have with your doctor before your next refill. Stay with me through everything, because the section on what researchers call the prescribing cascade, the mechanism by which one medication quietly creates the need for another, is the piece that most people find the most difficult to hear and the most important. Before we go further, drop a comment right now. Tell me your name and where you're watching from. And tell me this: how many prescription medications are you currently taking? I want to know how many people watching this are carrying a medication list that no single physician has ever reviewed as a complete picture. I read every single comment. Let us begin. Before the 5 combinations, you need to understand one thing, because without it, you might hear everything I'm about to tell you and think, my doctors are careful. They would have caught this. Someone would have said something. Here is why that often does not happen. Every medication that reaches a pharmacy has been tested for safety. The clinical trials that produced that evidence were rigorous. The data was real, but those trials tested the medication against a placebo, or occasionally against one other drug. They did not test it in a 71-year-old woman who was already taking 6 other medications for 6 other conditions. The combination was never studied, because it cannot be studied. The number of possible drug combinations in a patient taking 5 or more medications is in the hundreds of thousands. No trial system can test them all, and so your physician prescribes each medication based on evidence for that medication. The interaction risk, what happens when all 5 meet simultaneously in your bloodstream, your liver, your kidneys, your brain, is estimated, not known. Managed through caution and monitoring, not through certainty. This is not a failure of medicine. It is an inherent limitation of how medications are developed and tested, but it means that the person who understands the complete picture of your medication list is not your cardiologist, not your internist, not your orthopedist. It is supposed to be you, or someone who reviews your complete list with that specific question in mind. And most of the time, that review never happens. There is also something called the prescribing cascade. It is the mechanism by which polypharmacy quietly grows without anyone noticing. A medication causes a side effect. That side effect looks like a new medical condition. A second medication is prescribed to treat it. The second medication causes its own side effect. A third is added. Each prescription is individually appropriate. Each physician is responding correctly to what they are seeing, and no one realizes that the first medication started the chain. The classic example: a blood pressure medication causes a cough. The cough is treated with another medication. That medication causes acid reflux. The reflux is treated with a proton pump inhibitor. The proton pump inhibitor reduces B12 absorption. The B12 deficiency causes fatigue and cognitive changes. The cognitive changes are evaluated as early dementia. A patient who started with one condition now has a dementia diagnosis. The original blood pressure medication, and a simple switch to a different class that does not cause cough, was never identified as the beginning of the chain. This is not hypothetical. This pattern appears in geriatric medicine literature consistently enough that the term prescribing cascade has its own definition, its own body of research, and its own chapter in every geriatric pharmacology textbook. And yet it almost never gets discussed in a standard 15-minute appointment. Keep both of these frameworks in mind, the untested combination and the prescribing cascade, as we go through the 5 most dangerous patterns in polypharmacy. Let me tell you about a man described to me as a retired judge, 74 years old, from Mississippi. He had been taking 5 medications for 3 years: blood pressure, cholesterol, a sleep aid, an anti-anxiety medication, and a muscle relaxant for chronic back pain. Each prescription had been written by a different physician. He had never had all 5 reviewed together. He came to my clinic because his daughter was concerned. He had become, in her words, a different person. Slower, confused at times, falling asleep mid-conversation. His memory, once exceptional, he had spent 30 years reading and applying complex legal documents, was noticeably declining. His internist had ordered cognitive testing. The results suggested early dementia. I looked at his medication list. 3 of his 5 medications had documented central nervous system depressant effects. The sleep aid, the anti-anxiety medication, and the muscle relaxant were each individually sedating. Taken together at night, in a 74-year-old body with reduced metabolic clearance, they were producing a cumulative sedation that was suppressing his cognitive function every single day. This is not early dementia. This is polypharmacy presenting as dementia, and it is one of the most frequently missed diagnoses in geriatric medicine. We worked carefully with his care team to taper and substitute 2 of the 3 medications over several months. 6 months later, his daughter called. She said, "The man who sat across from me last week was my father, not someone I was watching decline. My father. He was not demented. He was over-medicated, and no one had ever looked at all 5 medications together." Type the word 5 in the comments right now if you are currently taking 5 or more medications. I want to know how many people watching this are in this situation, and how many of you have ever had a complete medication review. Now, the 5 most dangerous patterns. Pattern 1, CNS depressant stacking. This is what happened to the judge from Mississippi. 3 classes of medication have central nervous system depressant effects that are well established in the literature: benzodiazepines and Z drugs, sleep medications and anti-anxiety medications, opioid pain relievers, and anticholinergic medications, certain antihistamines, bladder medications, older antidepressants, muscle relaxants. Each of these classes carries sedation risk alone. When 2 or 3 are taken simultaneously by an adult over 60, whose liver metabolizes medications more slowly, whose brain is more sensitive to chemical sedation, whose blood-brain barrier is more permeable, the combined effect is not additive, it is multiplicative. A 2024 meta-analysis found that adults over 60 taking 3 or more CNS active medications simultaneously had a 51% higher risk of cognitive impairment compared to those taking none. Not 51% above baseline, 51% above those taking 1 or 2. The symptoms, cognitive slowing, memory gaps, fatigue, confusion, look exactly like aging. They look exactly like early dementia, and they are almost universally attributed to one of those 2 things rather than to the medication combination producing them. If you watched the sleep disruption video, you already know that diphenhydramine, the active ingredient in most over-the-counter sleep aids, is an anticholinergic drug. It is also pattern 1 on today's list. The same medication, 2 different videos, 1 complete picture. Pattern 2, the blood thinner interaction cluster, warfarin and direct oral anticoagulants, blood thinners taken by millions of adults over 60 for atrial fibrillation, clot prevention, and cardiovascular protection, interact with an extraordinary range of commonly prescribed medications in ways that can shift bleeding risk dramatically. NSAIDs, including over-the-counter ibuprofen and naproxen, certain antibiotics, some antifungal medications, aspirin, even some supplements, fish oil, vitamin E, ginkgo. The interaction does not always produce obvious symptoms until it produces a serious bleeding event. An adult taking a blood thinner who adds ibuprofen for knee pain, purchased without a prescription, taken for a week, never mentioned to the prescribing cardiologist, has meaningfully elevated their bleeding risk without anyone knowing. Research published in the Journal of the American Geriatrics Society found that among adults over 65 taking anticoagulants, nearly 1 in 4 were also regularly taking a medication or supplement with documented interaction risk, nearly 1 in 4. The solution is not to avoid blood thinners. It is to ensure that every substance entering your body, prescription, over-the-counter, supplement, is known to the physician managing your anticoagulation. Pattern 3. The kidney clearance problem. After 60, kidney function declines gradually. Most adults are not aware of it because it produces no symptoms until the decline is significant. But the kidneys are responsible for clearing many medications from the body, and when they clear more slowly, medications accumulate. A drug dosed for a 40-year-old kidney stays in the body longer in a 70-year-old kidney. The effective dose, what is actually circulating, is higher than the prescribed dose intended. When 5 medications are all being cleared more slowly than intended, the combined circulating levels can be meaningfully above what any of the individual prescriptions was designed to produce. Metformin, commonly prescribed for diabetes, can accumulate to dangerous levels when kidney function declines, a risk that requires monitoring most patients are not aware of. Certain antibiotics, pain medications, and heart medications carry similar accumulation risks. The solution is a kidney function test, a simple blood draw measuring creatinine and GFR, reviewed specifically in the context of your complete medication list, not just to see if your kidneys are functioning, but to see if your kidney function is appropriate for the medications you are taking at the doses you are taking them. Pattern 4. The timing crossfire. When 2 or more medications that affect blood pressure, heart rate, or fluid balance are taken simultaneously, their peak effects can collide in ways that no single prescription accounts for. A diuretic taken in the morning pulls fluid from the bloodstream. A calcium channel blocker taken at the same time relaxes arterial walls. A beta blocker slows the heart. Each is individually appropriate. But when all 3 peak simultaneously in a 70-year-old cardiovascular system with reduced compensatory reserve, the combined effect on blood pressure can drop it to levels that produce dizziness, falls, and fainting, without any single medication being at a dangerous dose. This is not overdose. It is timing crossfire. And it is a common, under-recognized cause of falls and hospitalizations in adults taking multiple cardiovascular medications. I covered bedtime dosing for blood pressure medications in a previous video. The polypharmacy dimension goes further. It is not just when you take each medication, but whether the peak effects of all your cardiovascular medications are hitting at the same moment, and whether your system can handle that simultaneous load. A medication timing review that maps when each drug peaks, not just what it does, is something most patients have never been offered. Pattern 5. The invisible 5th drug. This is the one that almost never gets discussed in a medical appointment, because physicians rarely ask and patients rarely volunteer. Fish oil, vitamin E, St. John's wort, ginkgo biloba, CoQ10, magnesium, high-dose vitamin D. These are not neutral. They interact with medications. Some thin the blood. Some affect how medications are metabolized. Some directly counteract the intended effect of a prescription drug. St. John's wort, one of the most widely used supplements among adults over 60 for mood and sleep, reduces the effectiveness of blood thinners, certain heart medications, and several antidepressants through a well-documented metabolic pathway. The physician who prescribed those medications has no way of knowing you are taking it unless you tell them. A 2022 study found that among adults over 65 taking 5 or more prescription medications, more than 40% were also taking at least one supplement with documented interaction potential. Fewer than 30% had disclosed those supplements to their prescribing physician. The supplement is not on your prescription list. It is not in your pharmacy record. It exists in a blind spot that standard care almost never illuminates. Now, here's what you can do about it. Step 1. Create a complete medication list. Today, not just prescription medications, every supplement, every over-the-counter medication, every vitamin, every herbal preparation, everything you take, even occasionally, even irregularly, even things you consider harmless. Write it down. Every item, the dose, the time of day you take it, and the physician or condition that prompted it. This list does not exist in any pharmacy record, any electronic health record, or any doctor's office. It exists only if you create it. Step 2. Request a formal medication review, not a casual conversation at the end of an appointment about something else. A dedicated appointment framed explicitly as a medication review. Many geriatricians and clinical pharmacists offer this specifically. Bring your complete list. Ask these specific questions. Are any of these medications duplicating each other's effects? Are any interacting in ways that could be causing symptoms I am attributing to aging? Have any of these become unnecessary since they were originally prescribed? Is my kidney function appropriate for the doses I am currently taking? Step 3. Disclose everything to every physician. Every physician who prescribes a medication should see your complete list, including supplements, at every appointment, not just the medications they prescribed, everything. This is a burden the healthcare system should not place on patients. But until medication reconciliation becomes systematic, the only person who can ensure every physician has the complete picture is you. When you call or see your physician, say these exact words. I would like to request a formal polypharmacy review of my complete medication list, including supplements and over-the-counter medications. I want to specifically discuss whether any of my current medications are interacting in ways that could be contributing to my symptoms, and whether any prescriptions have become unnecessary since they were originally written. That sentence will accomplish 3 things. It will signal that you understand the difference between individual medication safety and combination safety. It will introduce the specific term, polypharmacy review, that activates a more thorough evaluation than a standard medication check. And it will open the door to a conversation that most physicians welcome, but rarely have time to initiate. A physician practicing good geriatric medicine will engage with that request directly. And if the answer is that no one has ever reviewed your complete medication list as a system, that answer is important information. I want to come back to the woman who brought the list. She was not unusual. She was careful, informed, compliant, and suffering from something that none of her 4 physicians had the complete picture to identify. We conducted a formal medication review. We identified a prescribing cascade, an acid reflux medication that had been added to treat symptoms caused by a blood pressure medication that had been running undetected for 3 years. We identified a combination of 2 medications that was contributing to her chronic fatigue in ways neither prescriber had recognized. We worked with her care team over 4 months to simplify her regimen from 7 medications to 4. She came back to see me 6 weeks after the final change. She said, "I thought this was just what 71 felt like. I thought I had run out of good years." She came back 4 months later. She had started walking every morning again, something she had stopped doing 2 years earlier because she was too fatigued to finish the block. She had rejoined the book club she had quietly resigned from. She was cooking again, something her daughter had not seen her do in over a year. She had not run out of good years. She had been carrying a medication burden that no single physician had ever seen all at once. And when someone finally looked at the whole picture, the picture changed. Your medication list is not just a list of treatments, it is a system. And systems have interactions that individual components do not. Somebody needs to look at your system. If this video gave you something your doctor has never once said out loud, please subscribe. I make videos like this every single week because the information that changes outcomes is not always the information that fits in a 15-minute appointment. And before you go, next week I am covering something that connects directly to everything we discussed today. The specific laboratory tests that can reveal whether your current medication regimen is quietly damaging your kidneys, your liver, and your bone marrow. Tests that most seniors are never ordered unless they ask. If you are taking 5 or more medications, that video is essential viewing. Leave a comment below. How many medications are you currently taking? And has any physician ever reviewed your complete list, including supplements, as a single system? I am Dr. Harris. Take good care of yourselves. I will see you in the next one.